investigation of choice, ultrasound. So now we said that all stones in CT except gallstones. What about CBD stones? That's another exception. So now CBD stones, the difference comes in that ultrasound may not be very reliable. Your entire common bile duct, the distal most part is going to open into the duodenum. We say that air is the enemy of ultrasound. So if the CBD opened into the duodenum, you're not going to be able to see the distal CBD in a lot of patients, right? Because the duodenum may be filled with air. In very thin patients, lean patients, you may be able to see, but in most cases, we can't see the distal CBD. So most of the times, these stones or distal CBD pathology will be missed on ultrasound. So then what is the best investigation? So now let's talk about the approach to obstructive jaundice or any cause like CBD stones, which is causing the obstructive jaundice. First off, they'll tell you that there's a patient who has come to you with jaundice. There are pale stools. They'll give you lab parameters like direct bilirubin is raised. They'll give you markers of obstruction like ALP, GGT being raised. And then they'll ask you, what is the next step? So the first investigation that you will do remains ultrasound. It may not be the best, but it has no radiation. The first one that we will do is an ultrasound. Now, ultrasound may or may not show you the distal CBD, but what you will definitely see is the proximal CBD. So this is where you can see this appearance, where this is the portal vein. The biggest structure of the portal triad or the hilum is going to be the portal vein. Anterior to portal vein, what you see here is the dilated CBD. Normally, it is very narrow. You will not see this like a barrel. But here you can see these two almost parallel structures here, and this is what has been referred to as a double barrel sign. Sign doesn't matter. What matters is anterior to portal vein, we have a dilated structure. Usually what happens in the exam, they tell you all of this lab parameters and they tell you that the ultrasound showed a CBD which is dilated. So that is what ultrasound will show us. It shows us a dilated CBD. CBD is considered to be dilated if it is more than 6 millimeters. Okay. So ultrasound told us that there is obstruction. CBD is dilated. But what is the cause? How do I know? So then the next step or the best investigation is going to be MRCP. As the name suggests, it's an MRI sequence, magnetic resonance cholangiopancreaticography. Cholangio meaning CBD, pancreaticography meaning main pancreatic duct. So this is where we are going to see the CBD, and can you appreciate this thin structure here? This is the main pancreatic duct, and both of them can be seen opening into the duodenum. So this is MRCP. A few points about this. We do not use any contrast media for MRCP. We use the intrinsic bile, which is a fluid. Do you remember World War II? We remember that water is white on T2. So what we use is a T2 weighted sequence. We make it very heavily T2 weighted such that only structures which are T2 hyperintense are visualized. Everything else is black. Do you understand? I made sure that only things with fluid should be white. Everything else will be black. So that's how we can appreciate that, okay, this is the bile, bilirubin or bile containing CBD, which is filled with fluid, hence white. So this is where we don't need contrast. We use a heavily T2-weighted image. That's the first advantage. The second advantage you all know is this has no radiation because it is MRI. This is non-invasive. So all of these are the advantages, and that is what makes MRCP the best investigation. Look at the CBD here. You can see these are the intrahepatic bile ducts, and this is the common bile duct here. And can you see one black colored stone here? So this is what is called as a signal void. Basically, there is a void of the signal. There is no bile there. It is replaced by a stone. So that's a CBD stone. So this is how you're going to pick up CBD stone. So the investigation of choice for a CBD stone is MRCP. What now? How do we manage a CBD stone? So remember the gold standard. What did we say about gold standard? That it is diagnostic as well as therapeutic. So the gold standard for a CBD stone is ERCP. What is ERCP? E for endoscopic. Yeah, can you see this endoscope here? So we see an endoscope. You take an endoscope into the duodenum, you cannulate the papilla, and you enter the CBD, and I put contrast. So that is where this involves iodinated contrast, and then I take an X-ray, so there is involvement of radiation. So this is an invasive technique that uses contrast and radiation, and that is where I'm going to see this image here, where you can see we have put contrast inside the CBD, and can you appreciate there are all of these filling defects? The stones we know are not radio opaque, they're radiolucent, and we can see that the contrast outlines them, and that is what we call as filling defects. So these are the filling defects. You can also see the endoscope here on the image that helps you recognize ERCP. So endoscopic retrograde, you're going from the other end, cholangiopancreaticography. You are inside, you can remove the stones now as well. So this becomes the treatment of CBD stone. Did you understand? So in cases of obstructive jaundice, you have to remember it's ultrasound followed by MRCP followed by ERCP. The only potential confuser that they can give you here is, what if ultrasound only shows me that there is a distal CBD stone? In that case, now do I need MRCP? Then I don't need MRCP. If ultrasound would show you CBD stones, then go straight away for ERCP. But if they mention that ultrasound is showing me gallstones with dilated CBD, then what do you think should be the next step? Gallstones is independent. How do I know what's happening with CBD? So unless and until I mention CBD stone, remember you have to do MRCP to see the CBD stone. Are you understanding? So ultrasound followed by MRCP followed by ERCP. That is the protocol for obstructive jaundice. Then we have this image here. What do you see? This is an MRCP image. We can see that there is this irregular dilatation and narrowing. So you can see there are these dilated saccules followed by this narrowing. So this is what is called as a beaded appearance. Normally both of the sides of the intrahepatic ducts are involved. The diagnosis is PSC. What is PSC? It is primary sclerosing cholangitis. This is a pathology that is associated with IBD, inflammatory bowel disease. Within it, it's UC more than CV, ulcerative colitis more than Crohn's disease. And what you have to remember is this is a pre-malignant condition. This has a very high risk of developing cholangiocarcinoma, right? So beaded appearance, PSC, primary sclerosing cholangitis. They will confuse you with PBC, primary biliary cirrhosis. Remember that does not show you this beaded appearance. In that case, the MRCP is more or less normal. In advanced cases, you will see distal peripheral bile ducts being narrowed. Okay, so that's a late finding. You don't really need to know about it, but this image has been asked a lot of times. So here what we see is a spotter again. What can you see on this X-ray? You can see that along the pancreatic duct, there are these various calcifications. Can you see these white things on the X-ray? We know is calcium. So when you see calcifications along the pancreas and the pancreatic duct, this is what is a diagnosis of chronic calcific pancreatitis. When you see pancreas having calcification, that is chronic calcific pancreatitis. The investigation of choice for chronic calcific pancreatitis is ERCP. On ERCP, we again cannulate the pancreatic duct, and can you see this is the main pancreatic duct which is opened up, and you can see these various side chains which have opened up. So when you see these side chains, this is what has been described as the chain of Lake's appearance. As the severity increases, you will see this becoming more and more dilated. The main duct becomes more dilated, the side branch becomes more dilated. So that is what you see in chronic pancreatitis. Now let's look at the questions here. So we have a 6-month-old baby with bilious vomiting. We already discussed this. You can see these 2 bubbles here. So what is it? Double bubble sign, duodenal atresia. It is 3 bubbles, it's triple bubble. If you see a single bubble, then it is CHPS. Midway volvulus we have seen was the Costro appearance. Radiological investigation of choice for pheochromocytoma. So this word is very important. Remember, we have studied this in BTR as well, that investigation of choice for anything endocrine is usually going to be a biochemical test. It's not going to be radiology. Radiology mainly helps in localization, not the diagnosis per se. Same applies to pheo. For localization, the best investigation is MRI, right? So MRI is the radiological investigation of choice, not ultrasound or CT or FDG PET. For pheo, what we do is a DOPA PET. DOPA PET helps in cases of pheo, but still if asked to choose, you will go for MRI. Okay, so that is what you need to know here. Overall, the investigations which are done are going to be plasma metanephrin or urine metanephrin. Okay, so radiological investigation of choice is important. What you see in this case, you can see CBD folded upon itself. This is nothing but the Phrygian cap. What is Mercedes Benz sign? So this is something that you see in gallstones. Okay, we said that gallstones are radiolucent. We won't pick them up on X-ray or CT, but when you see them on X-ray CT, they tend to show this trapped air inside the lucent stones. So we know air is going to be black, right? So you see this black colored air shadow within the stones, and that is what is called as Mercedes Benz sign. So gallstones on CT or X-ray may give you the sign. Not very important. Polyp and cancer, you already know. What is this? So you can see the same image we have seen. We are seeing a signal void. This is CBD stone or cholelithiasis. What is this? You can see that there is a calcified lesion in the liver. This is our hydatid cyst. Hepatocellular carcinoma or FNH. Remember, for liver masses, what we tend to do is a TPCT, a triple phase CT scan of the liver. At your level, what you need to remember is we take an arterial phase and a venous phase. We give contrast, and then I take a phase where the contrast is in the arteries, and then I take a phase a bit later when the contrast is in the veins. HCCs have a property that they don't get blood from portal vein, but they take blood from hepatic artery. So in the arterial phase, this is going to show us enhancement. You know, vessels are there in a tumor. There is neoangiogenesis. So there is very rapid washout. So what you want to remember is when you see a liver mass with arterial enhancement, venous washout, we are describing an HCC, right? So that's what you need to know. FNH is a lesion with a central scar. We'll talk more about it in nuclear medicine. As of now, you want to remember a central scar is FNH. Fine. So this is about the liver masses. This was asked in FMG. So now looking at these signs, so this is a recent FMG question here. So football sign is something that we saw in image with pneumoperitoneum. So one is B. So this leaves us with 2 options. The rat tail sign you remember was CA esophagus, whereas bird beak was smooth paperin with achalasia. So B is 2. So we already have an answer just to confirm. 3 is A. Yes, string sign in CHPS. So string sign we also saw with Crohn and TB. But even in CHPS, when you do a barium meal, what you see is that the pylorus, suppose this is the stomach filled with barium, the pylorus is thinned out, and that is what is going to appear as a string. So that's correct. And inverted umbrella sign is the pulled up cecum. So when in TB you have the IC junction involvement, you are going to have the cecum and the ileum getting narrowed, and that is what looks like an inverted umbrella. It's also been called as Buzenick sign, Sterling sign. There are many signs that you just need to cure once. So this is about the signs. Next, abdominal pain, distension, chronic constipation. Look at the image. 2 tubes, coffee bean, A hostile. This indeed is sigmoid volvulus. The history also favors the diagnosis. Next, 48-year-old female presenting with right upper quadrant pain. Ultrasound shows us multiple GB calculi, but no wall thickening. So from this, I know that there are gallstones. There's no cholecystitis per se. CBD diameter 12 mm. That tells me that the CBD is indeed obstructed. We said anything more than 6 cm is dilated CBD. GGT is raised, ALP is raised, meaning there is obstruction, but they do not tell me whether there is distal CBD stone or not. So what do I have to do next? Right? That is MRCP. So MRCP to confirm. So what did I tell you? Don't be like gallstones means there are CBD stones. No, we got to see what is the cause of distal CBD obstruction. So that is where we need to do MRCP. Once MRCP confirms, then we will go for ERCP. Next, 40-year-old female comes with jaundice, pain abdomen, LFT reveals raised bilirubin and GGs. We can see that many variations of a similar topic that has been repeated a lot of times. Every time they change one thing and the answer changes. So you got to be very thorough with this topic. Okay. So what we see here is that the ultrasound shows me a scleroatrophic gallbladder. It's just a fancy way of saying that GB is contracted, and that is what we see in a patient with chronic cholecystitis. Again, now they tell me there's dilated CBD, but they also mention there are impacted calculi. So now that there are calculi, now what do you want to do? Now, is there a role of MRCP if ultrasound has already told me about the stones? Not really. So that is why MRCP is not the answer, and it is ERCP straight up, because ultrasound would show me the CBD stones. Are you understanding this? Let's look at one more question. 56-year-old male with obstructive jaundice shows a dilated CBD and intrahepatic bile radicals. So I can see dilatation, but no stone could be identified. CT also showed me similar findings. So now what do we need to do? Now I need to do MRCP. You know, when this actual question came, a lot of students were like, ma'am, MRCP option mein nahi. It was not there in the option, so we ended up marking ERCP. But what is MRI? MRI is MRCP, right? So MRCP is what is the sequence of MRI. So when MRI is in the option, you know that. Okay, so don't be fixated that, oh, MRCP is not there, let me go to ERCP. Just be with an open mind and look at the options and we'll reach the answer. Next, 60-year-old female with increased bubble sounds. We are seeing dilated small bubble loops and air in the biliary tree. This is a buzzword. Whenever you hear pneumobilia, it can be one thing only, which is gallstone ileus. Gallstone ileus is where you have a communication of the gallbladder with the duodenum. Because of that, a stone passes into the intestine, leading to small bowel obstruction. So that is where you will have air in the biliary tree, you will have small bowel obstruction, and you will have a gallstone. So when you see this triad of pneumobilia, small bowel obstruction, and gallstone, this triad is called as the Rigler's triad. Remember, pneumobilia, gallstone ileus. Portal venous gas, think necrotizing enterocolitis. So both of these are buzzwords. Portal venous gas, think of NEC. We remember stage 2B. We've studied that in PHBTR. But what is gallstone ileus? Pneumobilia, bind up having air. Understood? Don't be fixated on this history of hysterectomy. So a lot of students ended up marking small bowel obstruction because of adhesions. They thought it's adhesions, but no. Air in the biliary tree can't be seen in any adhesive obstruction, right? It will only be seen in gallstone ileus. 35-year-old male, severe pain abdomen, has a radius fracture for which he's taking a lot of painkillers. How is that relevant? NSAIDs, you know, can lead to peptic ulcers. Peptic ulcers can perforate, leading to pneumoperitoneum. So where do we look? We look at the left diaphragm or right diaphragm? Right diaphragm always. So under the right diaphragm, when you see that there is air, what is it? It is perforation peritonitis or pneumoperitoneum. What do you want to do next? Look at the options. Advising to stop painkillers. You're like, okay, right now you might die, but don't take painkillers later. Does it make sense? EFAST is an investigation we only do in trauma. Extended focused assessment sonography using trauma. Study this in surgery. No role here. Barium, we said, is contraindicated in any case of perforation. Barium can never be done. So the next step is exploratory laparotomy. It's a surgical emergency. We're going to go ahead and do an exploratory laparotomy. Okay, if IV fluids is mentioned, mark that as your appropriate next step. If it's not there, go for exploratory laparotomy. 8-month-old child after vaccination presents to the emergency with crying, meaning there is pain. Vaccination. Which vaccine? Rotavirus vaccine, most likely. X-ray abdomen is normal, no signs of free air. Ultrasound is done. What do we see? You see a target appearance. You can see a bowel within bowel appearance, which indicates intussusception. What do we do? What is the investigation of choice? It is air enema. Any enema, barium enema, saline enema, air enema. Basically, we want to create hydrostatic pressure so that we can reduce the intussusception, right? So the answer here is B. What is the least? Read the question very carefully. Lots of students just jump to the diagnosis, mark manometry, and come back. Then they later realize, oh, they are least useful. So what is the least useful? What are you seeing? First of all, you can see a smooth tapering here. This is achalasia cardia. Here, barium swallow does have a use. Upper GI endoscopy can be done to distinguish it from cancer. Manometry is the investigation of choice, but 24-hour pH monitoring has no role. That is what we do for cases of GERD. It has no role in achalasia or carcinoma esophagus. So the least useful is 24-hour pH monitoring. If that's the most useful, we go for manometry. Right? So this is what we had from GI. The last question here, 45-year-old male presents with colicky, pain abdomen with vomiting. They're showing us an X-ray. What is the diagnosis? So here the options are a bit tricky. It's not just small bowel, it's proximal versus distal versus large bowel, and there's nothing called a pseudo small bowel, so you can rule that out. So what you see here, first of all, in the X-ray are these loops which are essentially dilated. Can you tell me what are these loops? Jejunum, ileum, colon. You are right. We can see that there are loops which have folds throughout the lumen. Complete folds within the lumen are valvulae conniventus, and you know valvulae conniventus are a feature of jejunum. So these are the jejunal loops which are dilated. What about ileum? Is ileum dilated? Not really. We can see that within the pelvis there is no dilatation of any bowel. So this indicates that there is an obstruction somewhere between jejunum and ileum, indicating proximal small bowel obstruction. If this was distal small bowel obstruction, I would have had jejunum plus ileum dilatation. Getting it? So this is what is proximal small bowel obstruction. So with this, we complete the section of GI radiology. Next, we move on with the next system, that is genitourinary and women's radiology. So the first thing that we need to study in genitourinary radiology is going to be the signs on IVP. First of all, what is IVP? IVP stands for intravenous pyelography. This is where we're going to inject the contrast, just as we do for any other investigation, into the venous system. So you put a venous cannula, peripheral venous cannula, and you're going to inject the contrast. What did we study? We studied that the contrast is injected from the renal system. So around 10 to 15 minutes after the injection, the contrast is supposed to be excreted out from the kidneys. So at that time, if I take an abdominal X-ray, this is the kind of image I'll see. I see the collecting system of the kidney. Can you appreciate? These are the calyces, this is the pelvis, this is the ureter, which is entering into the bladder. So we just have to take an abdominal X-ray after injecting contrast around 10 to 15 minutes later, and that investigation is IVP, intravenous pyelography. Understood? So this is where we have to see some images and diagnosis. What are you seeing here? In this, we can see that the distal end of the ureter has this cystic sort of a dilatation. What is this called? This is what is called as adder head. Looks like a snake's head, yeah, which is more bulbous than the rest of the body. So this is what has been called as the snake head, cobra head, adder head, whatever you prefer. What is the diagnosis? The diagnosis is ureterocele. Ureterocele means the cystic dilatation of the distal end of the ureter. So this is a ureterocele. Look at the next image now. So normally, when we look at the calyces, the kidney are facing on the two sides, and then you have the ureter. But in this image, what you can appreciate is now the inferior poles are rotated and facing medially. So this is what is horseshoe kidney. So horseshoe kidney is where the inferior poles of the two kidneys are fused and meeting in the midline. So the IVP looks as if the inferior pole are trying to shake hands, right? So this is what we refer to as shaking hand calyces. Some people have also called it the flower vase appearance or the flower vase sign. So this is the IVP appearance. What has been very commonly asked these days is the CT appearance. So first, let's look at the image. Why did I call it CT? The moon is white. Is it NCCT or CCT? What do you see? You can see here that this is the aorta. In front of the CT, whenever you see that the vessel is filled with contrast, that is aorta. Vein is always on the right side. So on the right side, what you see here is IVC, which may or may not be filled with contrast. So we see aorta, IVC, aorta has contrast. So this indeed is a CCT. And then what do you see? These are the kidneys, and you can see that the kidney is meeting in the midline. This is what we call as the isthmus. So isthmus is the fused inferior core of the horseshoe kidney. We have taken a cut at this point, and this is the appearance we see where the two kidneys are meeting in the midline. Now, what if they ask me not the diagnosis? The diagnosis we know now is horseshoe kidney. They might ask me, what is this tiny little vessel anterior to the isthmus? I'm like, ma'am, how can they ask me such a tiny vessel? Do I need to know every single vessel? You don't. This vessel is important because if you know this vessel, you know the pathophysiology of horseshoe kidney. Horseshoe kidney, remember, or all kidneys in general form in the pelvis, right? You know, metanephroblastema gives rise to the kidney parenchyma. It fuses and then it comes up. So the two kidneys are forming in the pelvis and then they rise up. Now imagine this horseshoe kidney trying to come up. Normal kidneys go from the side, not an issue. This horseshoe kidney now is going to encounter the ventral branches of the aorta. The inferior most ventral branch is inferior mesenteric artery. So while my horseshoe kidney is trying to come up, it's going to encounter the IMA, and that's why there's a constant relation between the isthmus and the IMA. Whenever you see a vessel interior to the isthmus, it's got to be inferior mesenteric artery. Do you understand? So that is why a tiny vessel can be asked, because that indirectly tests whether you know how kidneys form or not. So that is what you need to remember, that inferior mesenteric artery is always going to be anterior to the isthmus, right? Which syndrome is horseshoe kidney more commonly associated with? Turner syndrome. So that's another question for you, horseshoe kidney associated with Turner's syndrome. Next, I'm going to show you 4 images which students frequently confuse. All 4 of them very frequently tested as well. So look at the first image. The first image is an abdominal X-ray. What do you observe? We observe that the right kidney, I hope no confusion with right and left at this point, so always this right is left. We observe that the right kidney is completely calcified. It looks as if it is filled with cement. So white, putty cement. So this is what has been called as the putty kidney. This putty kidney is what we see as an end stage. Remember how hydatid as an end stage was completely calcified? Putty kidney is the end stage of genitourinary TB. Once TB has destroyed the kidney completely, the end stage is a completely calcified kidney called as putty kidney. So this is a kidney which has no function left, and that is why this is as good as doing an autonephrectomy. The body has destroyed the kidney. So this is what you see as putty kidney, completely white, calcified kidney, end stage of genitourinary TB. They may describe in the question that the patient has sterile pyuria. Sterile pyuria is a buzzword for TB. It means that there are pus cells, but you don't see the bacteria, which is E. coli in this case because it's tubercular. Alright, so that's putty kidney for you. Now distinguish it from this particular image. In putty kidney, you had a completely calcified kidney. Whereas here you can see the calcification is conforming to the collecting system. So what is this big stone here? This is what we call as staghorn calculus. The staghorn calculus occupies the collecting system. Remember, this is usually formed by struvite, right? What is struvite? We've studied that in surgery as well. Struvite is your triple phosphate stones. Okay, so this is your triple phosphate struvite. You remember the coffin lid appearance? We'll have this coffin lid appearance of the crystals associated with Proteus infection. Proteus is urease positive, so this is promoted in alkaline pH. These are all of the associated questions you may get from Staghorn. Now look at the third X-ray here. Can this be putty kidney? It can't. Putty kidney can't be bilateral. Second, is the Staghorn? No. This is where the complete kidney shows me calcification, but it's not the complete kidney as well. It is not even like putty kidney. What's the difference? You can see that now this calcification is occupying the medullary pyramids. Yeah. So when you see bilateral calcification involving the medullary pyramids only, this is what we call as medullary nephrocalcinosis. So this is what is nephrocalcinosis, calcification of the medullary pyramids. This is where the kidneys are functional. Okay. This is not like putty kidney where the function is lost. Here the kidneys are functional. It's just that the pyramids have calcium within there. Fine. So that's the first point. Apart from this, what you need to remember, what are the causes? So this can be seen with congenital conditions like medullary sponge kidney, which may show you calcification of the pyramids. The second association you want to remember is any cause of hypercalcemia. Anything like hyperparathyroidism, sarcoidosis can eventually lead to this. So hypercalcemia is a very important consideration you need to keep in mind. Now look at this image. So this is where you are being shown an IVP. They mentioned in the question that there was a delayed IVP which was taken. What can you see here? Look at this. First of all, on the left side, this is what normal collecting system looks like. And now look at the abnormal right side. You can see that the complete kidney is swollen. This is what is called as hydronephrosis. Yeah, the kidney is completely swollen and retaining the contrast. Why? Because there is obstruction at this point. There is obstruction at the level of the pelvic-ureteric junction. This is the renal pelvis, and this is where you're supposed to have the ureter taking the contrast. But here there is an obstruction at this level, resulting in retention of contrast even in delayed images. So this is what is diagnostic of PUGO. PUGO meaning pelvic-ureteric junction obstruction, obstruction between the junction of the renal pelvis and the ureter. Fine. So this is what is very important to see whether they are mentioning IVP or not. When this question came, a lot of students marked putty kidney and came back. Can it be putty kidney in an IVP? Never. Putty kidney is non-functional. It will not take up the contrast only. So this, if they mention IVP, you have to be very careful. So I've kept the 4 most confusing images together so that you understand the differences. All right. Moving on to cysts now. So I revealed the answer, but now forget about cysts and see this lesion. First of all, which kidney? Right or left? You can see that there is a lesion in the left kidney. If I ask you what is the diagnosis? A, RCC, B, renal cyst, C, angiomyolipoma, D, all of the above. What do you think should be the answer? You have to see the lesion characteristics. Don't jump to the answer. Look at the color or the density of the lesion. Try and match it with something that you can see from the image itself. Internal reference is always the best. So you can see that, ma'am, this gray color I can see here also. I can see here also. They look exactly the same. So what is common to all 3 of them? Gallbladder has bile fluid. Spinal canal has CSF, fluid. So the lesion has fluid. So fluid containing renal mass is a renal cyst. Do you remember Hounsfield Unit 0? This is what that looks like, the gray color. So this is how you diagnose a simple renal cyst. For cysts, when you have septations, you have calcification, you have enhancing component, that is what is called a complex cyst, which may have risk of malignancy, and that is what is the Bosniak classification. Taught that to you in surgery BTR, but here just mentioning the name. So complex cyst is Bosniak classification. Now look at this image. My first question to you is this X-ray, CT, MRI, ultrasound. So what you see, the bone is black. So this indeed is an MRI. On MRI, what do you see? You see that both of the kidneys are enlarged and they have these multiple hyperintense cysts here. So what do you see? This is autosomal dominant polycystic kidney disease. Why autosomal dominant? Why not autosomal recessive? First of all, autosomal recessive polycystic kidney disease is going to be seen in infants, right? This is an adult patient that has been shown to you. These ARPCKD, basically these babies are going to develop CKD by infancy, so they usually die by, young childhood. So that is one point. Apart from that, morphologically, ARPCKD will not have these big cysts. The outer contour in ARPCKD is going to be smooth. Here you can see these multiple large cysts. In ARPCKD, you're going to have a smooth contour. You're going to have these microcysts, small cysts at the corticomedullary junction that we call as microcysts. The cysts are so small that overall, what you see are two very enlarged kidneys and with a very, very echogenic appearance on ultrasound. Forget about that. Just remember that the outer contour is smooth. They are not these big cysts. So if I ask you, can this be ARPCKD? Your answer is going to be no, ma'am. We'll never see these big cysts in ARPCKD. So this is autosomal dominant polycystic kidney disease. Just an IVP image of the same. What will happen now? The collecting system is trying to navigate through these multiple cysts, isn't it? So this becomes very, very splayed and kind of looks like a spider leg. So this is the spider leg sign on IVP of polycystic kidney disease. Not just that, if you do a nephrogram, it may show you the Swiss cheese appearance. So just remember these two names in context of autosomal dominant polycystic kidney disease. Right? So this is all about renal cysts. Very, very important. Let's talk about renal masses now. So there are three main masses, three features, three syndromes. The first one, the right kidney, what do you see? You see that there is a very heterogeneous mass which shows a lot of necrosis within. Whenever you see such a heterogeneous necrotic mass lesion, this is the most common RCC. This is clear cell RCC. So this is the most common RCC, clear cell RCC. Histopatch, just to correlate and finish it right here, right now. Why the name clear cell? Because this has the presence of glycogen and lipid within the cells, giving them this clear appearance. Clear cell RCC is associated with the syndrome. Can you name the syndrome? If I tell you this patient has cerebellar hemangioblastoma, pheochromocytoma, what is this syndrome? This is VHL, 1 Hippel-Lindau, clear cell RCC, hemangioblastoma, pheochromocytoma, 3 letter of VHL, chromosome 3P. So that's clear cell RCC. Look at the next image. Can you see that there is a mass lesion and the feature is there is a central stellate scar. So when you see a mass lesion with a central stellate scar, what is the diagnosis? So here the diagnosis becomes either an oncocytoma. If this is not in the option, go for chromophobe RCC. So oncocytoma or chromophobe RCC, central stellate scar. And what you see here are these plant cells. This is what has been likened to plant cell containing chlorophyll, and they call this as racinoid nucleus. So this is oncocytoma, chromophobe RCC syndrome with this. If you have a person with a mass lesion in the kidney, lung cyst, fibrofolliculoma, literal face of a patient with follicular-based lesions, what is this syndrome? This is Birt-Hogg-Dube syndrome. So this is Birt-Hogg-Dube syndrome. It is associated with a mutation of folliculin gene. This is oncocytoma. The third mass lesion where you now see the characteristics, and again, we said internal reference when in doubt. You can see this lesion is black. We said only two things have a negative Hounsfield unit. Either it's fat or it's air, yeah? So it has to be one of these. Internal reference, this is the air density, black. This is the fat density, subcutaneous fat. Can you see how it is not as black as air, but as black as fat? Meaning this is a renal mass containing fat. What is it? So there's only one mass containing fat. This is angiomyolipoma of the kidney. You can read the word. It will be right there staring at you in the options. When you hear the word fat, think black on CT. So black on CT, negative Hounsfield unit is angiomyolipoma. Which syndrome will you rule out? If I tell you the patient has seizures, adenoma sebaceum, again face will be shown with these lesions. What is it? It is tuberous sclerosis. So tuberous sclerosis is associated with renal angiomyolipoma. Now, this is actually a hematoma, right? You know, in tuberous sclerosis, you have chromosome 9 and 16, hematin and tuberin genes being mutated. The various hematomas. Hematoma of blood vessel. Anything with blood vessels that hematomatous can bleed and lead to retroperitoneal hemorrhage. And that syndrome is called as Wunderlich syndrome. So that is what you want to remember. A ruptured AML can lead to Wunderlich syndrome. Fine. Just 2 extra scores for you. Renal score, you'll study this in BTR as well. Renal score is a score used to determine whether partial nephrectomy may be done or not. The procedure, surgery of choice for renal masses is partial nephrectomy. The radiological score to determine whether a mass is suitable to do so is the renal score. And Bosniak grading, as we said, is for complexes to assess their risk of malignancy. Right? So this is all about the renal masses. Now, just as an extension of the point that you know fat, look at this lesion. So this is a young 20-year-old female who's come to you with distended abdomen, pain abdomen. And this is the CT. So we're down at the level of the pelvis. You can see that from the SI joint. You can see the sacroiliac joint. So we're down in the pelvis. And can you appreciate there is a mass lesion which has what? Which has fat. You also recognize white of calcium. When you see a mass lesion in the pelvis with multiple germ cell derivatives, fat hai, calcium hai, soft tissue hai, what is it? This is what is a dermoid cyst. A dermoid cyst, also referred to as a mature teratoma. So in a female, young female, the most common germ cell tumor that you have is a mature teratoma or a dermoid cyst. And this is the radiological hallmark that you see fat and calcium within it, right? Now we move on to very, very important, a discussion of the next investigation that a lot of students confuse. That is MCU. MCU stands for micturating cystourethropography. Micturating cystourethropography. So now understand what we are doing. You put a Foley's catheter in a patient, and then you're going to inject around 300 to 400 ml of contrast, iodinated contrast, which we dilute with saline. Once you inject 300 to 400 ml, now the patient is going to say that I'm having this sensation of fullness and I want to void. So now you ask the patient, you remove the Foley's and you ask the patient to void. When the patient is voiding or micturating, that is when I take an X-ray. So when you take an X-ray while the patient micturates or voids, you're going to see something like this. So micturating, cysto meaning bladder, urethra meaning urethra. So this is where we filled the bladder with contrast. So the bladder is distended, patient is micturating, so the urethra gets visualized as filled with contrast. Did you understand this? So that is the procedure of MCU. Just to highlight the anatomy, you can see this is the urinary bladder. This part here is what is called as the posterior urethra. It consists of the prostatic urethra within the prostate and a very small part of membranous urethra. So prostatic membranous make up the posterior urethra. Then this most distensible part that you see here, this is what is the bulbar urethra. Okay, so this part here is what we refer to as the bulbar urethra, and this within the penile shaft is the penile urethra. So together, bulbar and penile make up the anterior urethra. So this is the anterior, whereas membranous prostatic make up the posterior urethra. That's the urethral anatomy there. Now, MCU is going to be very, very useful. It's the investigation of choice for two conditions. Look at the first patient here. This is a young child who's come to you with recurrent UTI. So when you have recurrent UTI in a child, what is the diagnosis? The most common cause of recurrent UTI in children, and this is reflux, vesico-ureteric reflux. What does it mean? Look at the MCU. We were supposed to see the urethra when the child micturates, but what do you see instead? You see instead that the contrast is going back into the kidneys, meaning this is where the contrast is refluxing back into the ureters. So this is vesico-ureteric reflux. There are 5 grades to VUR. So grade 1 is when you only are going to see the ureter. So if you only see the ureter, this is what we call as grade 1 VUR. Grade 2 VUR is when you see non-dilated ureter and the kidney. 3 is where you see mild dilatation. So that is where now you're going to see mild dilatation of the ureter and the kidney. 4 and 5 is where you have severe dilatation. What is the difference? In 5, you're going to have this ballooning. Okay, so this is where the difference comes. Look at number 4. In number 4, there is a lot of dilatation, but the papillae impressions are maintained. So this is where the papillary impressions are maintained. In 5, those papillary impressions are lost, and you can see this outward bulge now. That is what is called as ballooning. Here, it is still inward. So that's the difference between 4 and 5. They will not ask you so much depth, but at least 5 you should be able to recognize. And you see this gross ballooning outwards. So this is grade 5 VUR right here. So this is what you need to know, that for VUR, what is the investigation of choice? It is MCU. Another condition where MCU is the investigation of choice. Now, this is where a child comes to you with dribbling of urine. This is the most common cause of congenital urinary obstruction. So this may present in utero as well in very, very severe cases, but most of the time it's going to present after birth as this dribbling of urine or a poor urinary stream. So what is the cause? What is the diagnosis? You did the MCU, you can see this is the bladder, and now the posterior urethra you can see is dilated, and then the anterior urethra is almost not visualized. So this means there is some obstruction here. So what is that? That is a posterior urethral valve. There is a valve-like membrane at the level of prostatic urethra, usually at the level of verumontanum, which does not allow the urine to pass, resulting in urinary obstruction. So for PUV, again, what is the investigation of choice? It is MCU, which will detect the valve here. All right. What you need to remember, in severe cases, it can also be detected on an antenatal ultrasound. So this is an antenatal ultrasound of a baby with a PUV. You can see this is the urinary bladder, and this is the posterior urethra that is dilated, giving rise to this appearance that has been called as the keyhole sign. So this looks like a keyhole and represents the obstruction. What will you see associated with this? Oligohydramnios or polyhydramnios? So because the urine cannot go, we know urine, fetal urine is the main constituent of amniotic fluid. You will have oligohydramnios, and do you remember the sequelae that can result in Potter sequence, where severe oligohydramnios leads to pulmonary hypoplasia, which may result in death. You have abnormal phases called as Potter phases. So here you have to remember MCU, investigation of choice for two conditions, VUR and PUV. 3-letter words, all 4 of them. Okay, so this is about MCU. With that, we go on to urethral trauma now. In urethral trauma, the investigation that you're going to study is this one. So first we'll study the investigation, and then I'll teach you the approach to urethral trauma. So this is what we call as RGU. What does RGU stand for? RGU stands for retrograde urethrography. So this is where you're going to inject contrast from the meatus. This is where we don't put any Foley's catheter. You're just going to directly inject contrast from the external urethral meatus, and it's going to go enter the urethra and the bladder. So you can see this horizontal part here. What must be this? So now you know the anatomy, so you guys will speak with me. This must be the penile urethra. Where it takes a turn here, what must be this? This must be the bulbar urethra. Yeah, so this is how you recognize the bulbar urethra. And then this thin part. Now, why does this appear thin? Is there a stricture? No, because I'm putting the contrast on the other hand. This is how the posterior urethra will appear normally. It appears narrow normally here because we're going retrograde, right? So this is the normal thin posterior urethra that you see, and this is the bladder. So on an RGU, my main aim is to see, is there a continuous stream of urine or not? If there is a continuous stream of urethral opacification or contrast, it means that there is normal RGU. So this is how a normal retrograde urethropathy will appear. With this in mind, now let's jump to the approach to a patient with suspected urethral trauma. First of all, when will you suspect? What will be the history? Here, the patient will give you 2 buzzwords. First buzzword is inability to void. The patient will not be able to void urine. And secondly, we will see that there is blood at meatus. So this is very, very important, that inability to void urine with blood at meatus is the hallmark of urethral trauma. You need to remember the risk factors. For anterior urethral trauma, you may have straddle injury. Straddle injury means patient is walking, has a fall perineum first, so that's straddling of the perineum leading to anterior urethral rupture, whereas pelvic fracture is what is a risk factor for posterior. So you can remember P for P. So this is the clinical background of a patient with urethral trauma. So now what will be the next step? The next step that you have to ensure, before even I go to the next step, what is it that you will not do? When you have a patient who is suspected to have urethral trauma, remember what is contraindicated is Foley's. So Foley's catheter is something you'll never try and put in a patient who has blood and meatus and inability to pass urine, because in case he has a partial rupture and you put a Foley's, you're going to convert it into a complete rupture. So you never want to put a Foley's. That's the first point. So now can I say that if Foley's is contraindicated, by extension MCU is contraindicated, because you just saw that the first step of MCU is putting a Foley's. So this is where both of these are out. They'll be in your options and that's just ruled out straight up. So what do you want to do next? So the next step is the investigation of choice for urethral trauma, which is RGU. So that is why we said that I'm not going to put Foley's, I'm just going to inject contrast. If I see this, it is normal. Now let's take a look at our patient. So this is the RG of a patient with urethral trauma. Is this normal? This is not normal. What is the part which is ruptured? So let's see. The horizontal part looks okay. So penile is fine. This is the bulbar urethra, where you can see that the contrast is extravasating and you can see it doesn't go further. So what is my diagnosis here? You're going to report it as a bulbar urethral rupture. Yeah. So now what next? So this patient is saying, doctor, I have one problem in life. I want to pass urine. You please find some alternate route for it. So what is the alternate route we put? We put a SPC. What is SPC? SPC is a suprapubic cystostomy, meaning you directly puncture the bladder above the pubic symphysis, that is suprapubic cystostomy, and the problem is solved. The only thing you want to remember, what if the patient says that my bladder is not full, or you try and palpate and they give you that the urinary bladder is not palpable? Now can I rupture the bladder directly if it's not distended? I can't. So that is where what do? Nothing much. You ask the patient to wait. You're going to ask him to drink water and wait. Once the bladder becomes distended, that is when you go into an SPC. Understood? So this is what has been tested multiple times. Very, very important approach to urethral trauma. The recent favorite is bladder trauma. 2 to 3 years back they were obsessed with urethral trauma. Now they're obsessed with bladder trauma. So here what you want to remember, first of all, what is the investigation of choice? That is CT cystography. So CT cystography is the investigation of choice, wherein again the process remains very similar to an NCU. The first step is you put a Foley's, and now you're going to inject around 300 ml of contrast mixed with saline. Then you stop. You don't have the patient to menstruate. I now follow it up with a CT scan. So that is where I'm going to see this sort of an image. Now, if everything is normal, you're going to see the contrast remains in the bladder. But if there is any leak, now the contrast is going to extravasate. So that's what you're going to see. What is the pattern of leak here? So you can see this is the bladder, and the white contrast is around the bladder. So when you see this flame sign, like a flame, it's around the bladder, or some people call it like a molar tooth. So when you see this flame or molar tooth appearance, in short, when you see that the contrast is perivesical or in front of the bladder, prevesical, this type of bladder rupture is what we call as extraperitoneal bladder rupture. This extraperitoneal bladder rupture is the most common type of bladder rupture, and the management is conservative. You just have to put the patient on Foley's and the patient eventually recovers. But the more dangerous type is this one, where what do we observe? We observe that our contrast is now leaked on into the peritoneal space. You can see it surrounding the bowel loops or in the perihepatic space. So this is the one which is the intraperitoneal bladder rupture. It is not very common, but once it happens, this becomes an indication of surgery because the urine is leaking into the peritoneal space. So this is what is the approach to bladder trauma. If the contrast is around the bladder, it's extra. If it is going here and there, sometimes the image may not be very good. They might also give you an X-ray cystography, an X-ray instead of a CT. In that case, you'll see the contrast going here and there. But remember, here and there. If the contrast goes around the bowel into the peritoneal space, that's intraperitoneal bladder rupture. Yeah. Few more bladder appearances. What is this? You all know it looks like a Christmas tree. The bladder is vertically oriented with these multiple diverticulae. So Christmas tree bladder with multiple diverticulae around it. What is this? This is what is our neurogenic bladder. So this is neurogenic bladder, Christmas tree with diverticulae. Look at this cystogram here. You can see that the bladder looks like a teardrop. The bladder looks like a teardrop, or some people call it a pear-shaped bladder because it is being compressed. What is compressing the bladder? Anything in the pelvis. So it could be a fat overgrowth of the pelvis called as pelvic lipomatosis. It may be a pelvic hematoma. There will be multiple pelvic lymph nodes. So any cause of extrinsic compression of the bladder will lead to this teardrop or pear-shaped bladder. Look at this image here. You can see this white calcification surrounding the bladder or in the bladder wall. This has been called as the fetal skull appearance. This fetal skull appearance is what we see in schistosomiasis. So schistosomiasis can lead to calcification of the bladder wall. Remember, this is a risk factor for squamous cell carcinoma. S for schistosoma, S for squamous cell. I hope you remember bladder schistosoma is S hematobium. Remember terminal spine. Yeah, so that is schistosomiasis. What is this here? So now I'm showing you an ultrasound of the bladder, urinary bladder, and then what do we see? Same old stones. Remember gallstones. So now urinary bladder, you can also see these stones here. So these are our UB stones. They frequently are calcified. So when we look at the X-ray, can you see this? This appearance, like a star or a snowflake, is what has been referred to as a jackstone appearance. So this jackstone appearance is characteristic of a UB stone. You frequently get this question when they give you this is a post-menopausal female. First of all, is this a UB stone? Everything in the pelvis is not urinary bladder stone. What does a female have in the pelvis? A uterus. Sometimes a fibroid can grow to great sizes, and as menopause happens, the fibroids tend to undergo atrophy with calcification. So first of all, why is this not a bladder stone? Two reasons. A bladder stone will be in the center of the bladder. It won't be off midline. Secondly, it will be completely calcified. If you see closely, you can see there is this lamellated stippled sort of a calcification, more like a soft tissue mass developing calcification, right? So this is what is a calcified fibroid. So I wanted to discuss the three main deities of a pelvic calcification. You may see peripheral wall calcification of the bladder, that's schistossoma. You see completely calcified stone, that's a UB stone. Lamellated stippled sort of appearance, that is calcified fibroid. The history nature is going to be very, very important. With this, we go on to the ultrasound, early pregnancy ultrasound. What are the ultrasound features of an early pregnancy? So what you need to remember, the earliest feature or the first sign of a pregnancy is a gestational sac, a G-sac, which is going to appear as this black fluid-filled sac within the uterus. So this is what occurs slightly off midline. Can you see this is the midline? It's white to white at the endometrium, and what you see surrounding the endometrium is the myometrium. So this is anterior myometrium, this is posterior myometrium. You can see this fluid-filled sac slightly off midline, and this is what we call as the intradecidual sign. As the G-sac grows, it is going to be surrounded by two different decidua. For example, if this is the sac, there are going to be two decidua capsularis and paritalis. Capsularis and paritalis, CP. Yeah, so capsularis paritalis surrounded, and that is what we call as double decidual sign. So both intradecidual sign and double decidual signs are signs of gestational sac. When is the earliest that you can see a G-sac? That happens to be 4.5 weeks. So you want to remember, close to 4.5 to 5 weeks is when we will see it on a transvaginal sonography. If you ask me, what about transabdominal sonography? Only add 1 week, always. Don't remember both numbers, just remember TVS, you're going inside the vagina to look at the uterus more closely. You will precede it by 1 week. So TVS versus TS, TVS is always ahead by a week. Okay, so we remember only one value. TVS is 4.5. If they ask me TS, I just add 1 week to it. Yeah, so the earliest in intrauterine pregnancy can be detected is 4.5 weeks. So now we call this patient after a week. That okay, I'm seeing G-sac, we confirm it in a week. So in 1 week, what you are now going to see is the G-sac, which is the gestational sac, grows, and within it appears a yolk sac. So can you see this black gestational sac with a central ring? That is the yolk sac. So yolk sac appears when 1 week later, right? So on TVS, you want to remember 5.5. Yes, at 1 week. We call her, come back after 1 week. Now what do you see? We see that okay, G-sac has grown further. This is the yolk sac, and what appears is now the embryo or the fetal pole. So this is the embryo or the fetal pole. The earliest you can see this on an ultrasound is 6.5 weeks, 1 week later. So you remember 1 week, 4.5, and then you just keep adding 1. You don't remember all values, okay? So 6.5 weeks, we see the embryo and the fetal pole. In a few days, what we are going to see is the cardiovascular system. The first system to develop starts to beat, the heart beat. So we see the fetal heart rate, the fetal heart beating at this point. So if they ask you when do you see the fetal heartbeat, the earliest is 6.5 to 7 weeks. All right. This is the surest sign of viability of a pregnancy. Very, very important. You know, in gynae, you would have studied there are signs like Spalding sign, signs of intrauterine death, right? Where the sutures overlap. You have Robert's sign where there is air in the aorta. All of these are very late signs. The surest and the earliest sign that there is intrauterine demise or there is no viability of the pregnancy is when you don't hear the fetal heart beating. When will I pick it up? I can only pick it up after 6.5 weeks, right? So after 6.5 weeks, the surest sign of viability of a pregnancy is fetal heart beating. Did you understand that? As we go ahead 1 week later, now what you see, this has been asked frequently as a one-liner. This is what we call as the double bleb sign. So this is the double bleb sign. Don't confuse it with double decidual sign. What are the two blebs here? First of all, this largest sac is G-sac. Yeah. So you can see here, this is the embryo and there are two sacs. Now you can't really say which is yolk sac, which is amniotic sac, and there is no need to as well. But in this case, this is actually the amniotic sac and this is the yolk sac. Doesn't really matter. So what you need to remember that the baby is going to be surrounded by the amniotic sac and this is our yolk sac. Okay. So this is what you need to remember, that the two blebs here are the amniotic sac and the yolk sac. Frequently, the options will say G-sac, yolk sac. Those are not the two blebs. It's amniotic sac and the yolk sac, right? So this is what is the evolution, and you get many questions from these. Next, we go on to the approach to enlarged ovaries. So whenever you see enlarged ovaries, you have to ask yourself a question. Ovaries are enlarged, but what about the follicles? So look at the first case wherein the ovary volume is increased, right? So this is where you have bulky ovaries, increased ovarian volume, but look at the follicles. The follicles are small and arranged in the periphery like a string of pearls. So this is what is called as string of pearls sign or a pearl necklace sign, where you see multiple follicles, multiple small follicles arranged in the periphery. How many and how small? Remember the number 10. Volume more than 10 cc. Follicles more than 10 in number. Size less than 10 millimeters. So number 10 does the job. Now there are many papers which say you should consider more than 12. There are many which say more than 20. In practice, it doesn't matter. As a radiologist, I never count the number of follicles if I have to make a diagnosis of, what are we talking about? Talking about polycystic ovarian disease. So actually we don't really count the follicles. We look at the gross picture. What is the hallmark is there should be no dominant follicle. The multiple small follicles actually tell me what? The pathology in PCOD is that there is an ovulation. So the hallmark here is the number doesn't really matter. It's that there should be no big follicle. There should be no dominant follicle. Dominant follicle is every cycle, one of these follicles in a normal female will enlarge and that would ovulate. That's not happening in PCOD. So that's why all of these are tiny, tiny follicles arranged in the periphery. 10 is just easier to remember. So that's what you remember. Fine. So that's PCOD for you. In addition, can you see how the stroma here, that's another specific sign of PCOD, that the central stroma is increased in volume and it is increased in echogenicity, meaning it is hyperechoic. So the very specific sign of PCOD is stromal volume increasing, and that is what leads to hyperthecosis. There is more androgen production from the stroma here. So this is the appearance of PCOD. But when they tell me that there are enlarged ovaries with enlarged follicles, now the follicles are also enlarged. discharged. Now you have to look at the history very carefully. If they tell me this is a female who's undergoing ovulation induction or some sort of in vitro fertilization, it means the diagnosis is OHSS. What is OHSS? Ovarian hyperstimulation syndrome. The drugs that you were giving, maybe clomiphene citrate, maybe beta-HCG injections, have stimulated the ovaries too much, resulting in these large follicles. A very similar appearance you shall also see when you have a molar pregnancy, right? Remember the snowstorm appearance in molar pregnancy. Now, molar pregnancy produces very high amounts of beta-HCG. Because of that, again, the ovarian volume will increase here, and same appearance is going to be seen in theca lutein cysts. So theca lutein cysts are the cysts within the ovaries, bilaterally bulky ovaries, in a case of molar pregnancy. So you want to remember 3 degrees of enlarged ovaries. When the follicles are small, it is PCOD. When the follicles are large, look at the history. History of IVF means OHSS. History of molar pregnancy means theca lutein cyst. Right? Let's look at the questions from this. So here we have an RGU. They're asking us the finding. Let's see the RGU first. You can see that the penile urethra is normal. This is the level of the bulbar urethra. And what can we see? The bulbar urethra, instead of tapering normally in the distal part and almost involving membranous as well, has a stricture. So the better answer here is a bulbar stricture, right? So we see a bulbomembranous junction / a bulbourethral stricture. Straight up before reading this long history only, do you recognize the image? Medullary pyramids, calcification. So this is medullary nephrocalcinosis. With this background, let's see the question. 30-year-old male, fatigue, urination, increased thirst, weakness, discomfort. All of these findings are suggestive of hypercalcemia. You remember moans, bones, groans. So hypercalcemia has these signs. Can you think and tell me why polyuria, polydipsia? Because hypercalcemia, remember, is a cause of nephrogenic DI, right? So both hypokalemia and hypercalcemia can actually lead to nephrogenic DI, and that is explaining the symptoms. So this is actually a cause of hypercalcemia. You know, hypercalcemia leads to medullary nephrocalcinosis. So the best answer here is hyperparathyroidism. None of the others have any association with nephrocalcinosis. What do you think is the diagnosis? 45-year-old banker with vague abdominal pain, renal mass lesion, CT is being shown to you. I see the color black. When you see a black renal mass matches with the fat density, can you tell me the answer? We have to look for fat. We find lipo. It is angiomyolipoma. I hope you have no doubt here. 45-year-old female presents with abnormal uterine bleeding. The ultrasound is shown to you. What are we seeing? We're seeing that within the endometrium there is this vessel. This is a Doppler. We are seeing a feeding vessel sign. So this feeding vessel sign is indicative of a polyp. A polyp has a fibrovascular stalk. So that is what is this feeding vessel sign. It is suggestive of an endometrial polyp. Next, 34-year-old ladies using OCP since 5 months presents with amenorrhea. Now she was on OCPs. There is no last menstrual period in this case. So what is the gestational age? So you want to remember the best for gestational age, particularly in females who have irregular periods, who has forgotten her last menstrual period or is on OCP, is going to be the crown rump length. So as the embryo grows, right? So imagine this is the embryo. These are the legs. These are the hands. All right, very primitive looking embryo, but that's fine. So what you take is the length from the crown to the bottom of the buttocks. So this length here is called the crown rump length, and that is the best measure of gestational age. Remember, the gestational age is best in the first trimester. As you go on in the pregnancy, the accuracy of the gestational age on ultrasound keeps decreasing. So the best parameter is on the first trimester by crown rump length. This is a hysterosalpingography where you inject contrast into the uterus. You can see this is the normal uterus. The normal tubes look like this, and then they have spilling of contrast. But in this case, there is no spilling. You can see that the tubes, the distal part of the tubes have become this dilated, retort-shaped tubes. This is nothing but hydrosalpinx. This happens when you have obstruction at the distal end. The spill is not happening. The contrast is not spilling out because of obstruction. So this is bilateral hydrosalpinx. This is not normal. Normal will have a spill. What is cornual block? Cornual block is where here, this is the cornual end. This is where you will not even see the tubes, right? So that's how corneal block will appear. Asherman syndrome is where you have sign decay. So within the uterus, you're going to see these filling defects here. In this case, the uterus appears just normal. So that is what you have to remember here. Look at this HSG now. So first of all, can you see this metallic catheter? When you see this catheter is the Leach-Wilkinson's catheter or cannula, which is used for putting dye. Nowadays, we don't prefer Leach-Wilkinson. We either use a Carman's catheter or a pediatric Foley's. But either way, this is Leach-Wilkinson. And what you can see is only one horn. The triangular shape is not there. I can only see one horn of the uterus. And this is what is unicornuate uterus. So this is a Mullerian defect, unicornuate uterus. So with this, we complete genitourinary radiology. What we have next up is going to be thoracic radiology. Very, very important. Lots of important image-based questions are going to come from here. So beginning with the first chest X-ray here. When you look at the chest X-ray first, look for a side that is white or opaque as we call it. Whatever side has the opacity is definitely abnormal. So that's always the first step. The moment you see one side is opaque, the job is done. That okay, it must be which side in this case? Left side. Yeah, so right, left, never a confusion. This is right and left. So on the left side, you can see there's an opacity and you can see that it has this rising curve laterally. So this is what is called as a meniscal sign or an Ellis's S curve, right? Where the peak is lateral. Whenever you see something like this, the diagnosis is pleural effusion. Pleural effusion is fluid within the pleural space. Now, if this is just fluid, that is what we call as a hydrothorax. But in context of trauma, this is what you may also call as hemothorax. Everything is going to be same radiologically. Whether it is blood, whether it is chylothorax, whether it is hydrothorax, it all looks the same on radiology. So it's the history that will tell you whether it's pleural effusion or it's hemothorax, right? Sign. The sign as we discussed is the meniscus sign, also called as Ellis's S curve. The earliest finding that you're going to see, this is a lot of fluid, right? You can't really wait for so much fluid. The earliest sign that you will see, the fluid, when you are in a standing position. Erect X-ray, what is going to happen? This is the angle. This angle here is the CP angle. What CP angle? Costophrenic angle. So this is what we call as the costophrenic angle, usually is sharp. As the fluid keeps accumulating, this is where the blunting of the angle begins and then it forms this entire meniscus. So the earliest finding on the frontal radiograph is going to be the blunting of this CP angle here. What will be the mediastinal shift? Anything which is space occupying in the thorax or the pleural space is going to push, right? Pretty logical. It's going to push the mediastinum to the other side. So we are going to see a contralateral mediastinal shift being pushed to the opposite side. The most sensitive investigation, what do you remember? Any fluid, it is ultrasound. So ultrasound is the most sensitive investigation that you have of fluid. What about the most sensitive X-ray? So here I want to tell you some numbers also you may or may not remember. Overall, when you compare it with ultrasound, ultrasound can even detect 5 to 10 ml of fluid. It's the most sensitive. Compare it with the X-ray. The most sensitive X-ray here is ipsilateral lateral decubitus. Meaning if I'm suspecting fluid on the left side should be down. So when the left side is down, the fluid will gravitate and will form a horizontal level. So ipsilateral lateral decubitus is the most sensitive X-ray. Following this, the next in order is going to be, in terms of sensitivity, the next is a lateral X-ray, where you're on the side and you see the anterior posterior CP angle. That is more sensitive. Then a chest X-ray PA erect view, where the patient is standing, the most common one that you see here, followed by supine. Supine is the least sensitive radiograph. Supine X-ray to show you an opacity, you will just see a diffuse whiteness there, right? So for a supine radiograph to show you an opacity, we'll need somewhere close to 500 ml of fluid, which is a lot. A chest X-ray PA erect view will need somewhere close to